This is a case about which we had difficulties while taking decision on table. So this is a patient. He is a 74-year-old male. Background history of vascular risk factors like dyslipidemia, hypertension, and type 2 diabetes. He had coronary artery disease. He underwent CABG in 2010. He was on dual antiplatelet and statin, that is ecosprin and clopidogrel along with atorvastatin. And he had one episode of TIA, that is left hemispheric TIA in March 2021 while on dual antiplatelet. So during that time, he was initiated on ticagrelor and like clopidogrel was switched to ticagrelor and ecosprin. Following that, he had symptomatic seizures. He was kept on levetiracetam 500 mg per day. And while on this antiplatelet therapy, he had one more TIA, that is in August 2022. The TIA lasted for less than 5 minutes. During that time, his MR was diffusion negative. So this is the first, on left side, we are seeing the first scan, which was in 2021 March. We can see infarct in diffusion image. This is infarct pattern of carotid stenosis. In the second TAA, while on ticagrelor and aspirin, we have done another scan, which was diffusion negative, but there are some new lesions in flare, which was not there in previous scan. And during that time, the DSA was showing a tight stenosis amounting to 90 to 95% in left ICA origin. So considering this background, while on optimal medical management, he had recurrent TIA. So we considered him for revascularization procedure by stenting. So what on the day of procedure, here we can see this is the procedure day images. These are the procedure day images. Patient is having, we have reached till the ICA, and embolization protection device is there in situ, and we started doing angioplasty. So this is the angioplasty image. So what happened to the patient? Immediately after deflating balloon, patient had an episode of sudden aphasia. It is a global severe aphasia with sudden right hemiplegia. Hemiplegia to the amount that his power was almost 1/5. He was not at all moving. So we were, after that, patient became restless on the table. So we were not able to get a clear image of the distal circulation because the injection was in CCA. So here we have limited options, like whether to abandon the procedure or abandon the procedure and go for CT to look for any acute bleed or acute infarct related early ischemic changes, versus go ahead with the DSA, but here we are not able to get proper images because of the movement artifacts. And the possibility of getting a major vessel occlusion is we considered very less because there is embolization protection device, the failure rate of which is 1 to 3%. So here we have considered in going ahead with stenting the patient, because even if there is a major vessel occlusion, we can have a luminal space to proceed to the distal vessel to do a thrombectomy. So considering that option, we have gone ahead with doing a carotid stenting rather than stopping the procedure. So here we can see we have deployed the stent in the ECA. Then subsequent flow is well maintained, and this is a DSA image which was taken after deploying stent. Here there are no major vessel occlusion. So here at this point of time we are confused what happened to the patient. So immediately after the procedure, after finishing the procedure, we have taken him for CT scan. This is the CT scan immediately after the procedure. Here we can see in axial and coronal images, there is a fullness of sulcal spaces on left side in almost entire MCA territory region, along with significant gray matter edema, which we can see in this image. So on the after the CT, while shifting the patient had seizure, which is amounting to the status epilepticus. So we have started loaded him on already he was on levetiracetam 500 mg OD dose. So we gave full dose of levetiracetam, and being this is a focal seizure, we considered straightforward on loading with lacosamide, and as it is a status, it was not getting controlled. We considered phenobarbital also. That time EEG was showing left hemispheric ongoing seizures with in between plates. The plates were after the 24 hours after controlling the seizures. So he was on multipharmacy for the status part, which was later on tapered. This is a scan which we have done almost the second day since the event. So compared to the previous, this is the image. At this point of time, we have initiated him on anti-edema measures, and patient was on ventilator with hyperventilation. So anti-edema being mannitol and 3% sodium chloride. So this is the second day scan. So this is the scan after 2 weeks. This is the MR diffusion image, which is showing left frontal cortical hyperintensity. So overall, the patient was having the features of reperfusion, which happened immediately after angioplasty. In literature, the reperfusion was mentioned as one of the complication in patient with carotid artery stenting, which was mentioned in literature as the earlier period is 4 hours. The earliest reporting time is 4 hours. In our patient, it happened immediately after angioplasty. So, this is the case basically. So, shall I go ahead with the literature part also, sir? Or so the cerebral hyperperfusion syndrome is rare but severe complication. The incidence was mentioned as
1 minute, Dr. Jafar.
Yeah, sir. Yeah.
I'm sorry, I was muted.
Sir.
Go back to this slide. Let us discuss a little bit what you else could.
Yeah, sir. Yeah.
Go back to the angio. Go back to the angio. Pre-angio. You only got the neck. Have you got the head? Go back. Back more. No, yeah. See, you only got the neck. So whenever you are doing a tight stenosis like this, you should always look at the intracranial circulation also.
The collateral status of further collateral status.
Don't talk about collateral status. Be specific. So in this patient, what you will need to know is there is a very good distal runoff.
Yes, sir.
Beyond the stenosis, very good distal runoff. So obviously the ACA and MCA on the left side will be feeling very well. With such a tight stenosis, is there any cross flow from the right side to the left side at all? You should always check that when you are doing the right side. I mean, when you are doing the angiogram. So take the don't do only left side, especially in such a tight stenosis. Always look at the cross flow from the right to the left, because if there is a good cross flow, the brain is not all that oligemic. See, when you have it such a tight stenosis and no cross flow, either from the ACOM or from the PCOM, then the whole hemisphere is totally dependent on what is coming from below. And this is the kind of patient who is prone to get hyperperfusion. So number one was always look at the collateral flow, ACOM and PCOM. That's number one. Number two is when the patient became restless, what we would have done is to induce general anesthesia. So we always do this, of course, with the anesthetic standing by. But as soon as this happens, if you induce general anesthesia, of course, you cannot monitor the patient. But at this time, it is better to see what is happening. So we would have given anesthesia, immediately taken a picture. Just now we don't know what has happened. You have put a stent there. The stent has opened the artery, but why did the patient immediately become freezing heavily? How long was the balloon kept inflated for?
Sir.
How long was the balloon inflated for? How many? 30 seconds, 1 minute, 2 minutes?
Sir,
the balloon when you did the angioplasty.
It was we have inflated and then 10 seconds, then deflated, sir.
So in such patients, usually when it is totally dependent on this side, we inflate, deflate quickly. We don't take time to do that. So that is one more thing that one should. I mean, this is in retrospect, but still, whenever there is a tight stenosis, there is no cross flow. Inflate, deflate fast.
Yeah.
And give anesthesia. So we've had this, I'm sure everyone has had this problem from time to time. So always have an anesthetist who has everything ready so that the patient can be intubated immediately to see what is happening. But what you have said is true. Hyperperfusion on the table is very rare because we've also had it usually later, an hour later or 2 hours later or 4 hours later. We've not reported it, but we've seen patients coming out of cath lab and getting convulsions a few minutes later, which presumably are due to the hyperperfusion.
Sir, we went ahead because even if there is a major occlusion, we cannot.
No. You have to go ahead. You have no choice.
Yeah.
Patient has aphasia. The other thing you didn't tell us what happened to the patient? You said the patient had aphasia, hemiplegia on the table, and whilst you were doing
then after that,
yeah,
he went into status, he went into status epilepticus.
Yeah, so you intubated, ventilated, but when he came out of all that, how was he clinically?
So patient, patient discharged with MRS1, sir. He went home walking. He had only residual right hand grip weakness alone.
Okay, so
it is, yes.
He recovered almost fully.
Yeah, sir. Yeah, almost.
The CT is very good. Obviously, the final CT that you showed us, you can go to that again. The second CT immediately post procedure shows massive brain swelling. Yeah, not this one, the one before this.
Yeah,
shows a lot of brain swelling, whereas this one is very good. It's almost innocuous.
Yes.
You can see the cerebral sulci, you can see the eye, and those two areas of hypotensity which are very small. So obviously the patient has recovered. So your later management was obviously very good. The control of fits and the elective ventilation, control of ICP was obviously very good.
Yes.
So the lesson is always have an anesthetist who will be able to induce anesthesia immediately. So anesthetic is not only to stand there and watch what is happening. If required, they should intubate. We've done that a few times, but so our anesthetist is very particular. She will always have everything ready in case intubation is required. But especially in such a patient, you should be forewarned. Very good case.
So, shall I go ahead with the?
Yeah.
What?
Yeah. Unless somebody else has something to say.
Yeah.
Yeah, go ahead.
Yes, sir. So this is a rare but severe complication. The incidence was reported as 1 to 5% in literature. So there was conflicting data regarding which is having more risk of cerebral hyperperfusion, whether carotid endarterectomy or carotid artery stenting, but both were having equal, not equal, both were having a risk of cerebral hyperperfusion. Patient selection is important, as sir said. So this is the literature from where I have taken rest of the slide. So the definition was it's a triad of unilateral headache or seizure or transient focal neurological deficit in the absence of a cerebral ischemia following any procedure, whether it is carotid endarterectomy or carotid artery stenting, or increase in the cerebral blood flow by 100% compared to the preoperative value, which was either by measured by either by TCD or the nuclear imaging, or even MR or CT perfusion itself. So there is a risk of cerebral hyperperfusion even in patients which are having intracranial after the intervention for intracranial disease, especially after thrombectomy. It was reported, and the incidence of cerebral hyperperfusion peaks at 12 hours after stenting and 6 days after carotid endarterectomy. The hemorrhage after carotid artery stenting was more common over carotid endarterectomy, probably because of the procedural anticoagulation and then strict dual antiplatelet post-procedure. So the pathophysiology which was explained is impaired cerebral autoregulation in ischemic brain, where the ischemic brain will have small vessels which were not able to tolerate the high flow immediately after the procedure, which eventually leads to a hyperperfusion followed by bleeding. So this is the most accepted theory. The other theories are free radical damages in ischemic brain and baroreflex or reflex breakdown because of carotid hand. So the clinical features, as I mentioned previously, headache or eye or facial pain and focal neurological deficit, seizures, sudden onset loss of consciousness, or features of intracranial hemorrhage, intracerebral hemorrhage. So the risk factors are old age, above 80 years, and presence of severe contralateral intracranial atherosclerotic disease, or even internal carotid neck, as in like extracranial severe internal carotid disease. That is also a risk factor which was mentioned. And presence of long-standing pre-existing hypertension and reduced cerebral vascular reserve. Cerebral vascular reserve can be assessed by a simple bedside tool of TCD, transcranial Doppler, either by acetazolamide or even CO2 reserve test. And presence of female sex chronic kidney disease, left-sided carotid disease. These are the observations where the patients were having higher risk of cerebral hyperperfusion syndrome. The imaging findings being patchy or diffuse white matter edema, predominantly involving the posterior parieto-occipital lobe, but may not be always, and the presence of focal infarction or petechial hemorrhage. At times, the MRI may be negative. So this is a classical image which is showing features suggestive of cerebral hyperperfusion, where we can see the presence of here we can see the loss of significant edema and the petechial hemorrhages. These are the subtle changes in a patient who is having unexplained focal neurological deficits. Then the imaging modalities which helps to identify cerebral hyperperfusion is that transcranial Doppler, which is a simple tool which can be used for identifying patient who is having are prone to develop cerebral hyperperfusion by doing simple MCA velocities. The MCA velocity more than 1.5 to means 1.5 to 2 times of pre-procedural value itself predicts cerebral hyperperfusion syndrome. Other images are other modalities are CT perfusion and nuclear imaging, and MR arterial spill labeling also one of the procedure which was explained. Especially this is non-contrast image, so very easy if patient is having any procedural AKI or something like that because of contrast risk. So here we can see this is the classical image. Here we can see a left-sided parieto-occipital area, the effacement of sulcal spaces, and the perfusion image. The CT angiography was showing hyperemia on left side because of increased blood flow, and then MR, the B image is arterial spin labeling image, which is showing increased perfusion and is indicated by that red mark in left side. So these are the images in patient with cerebral hyperperfusion. Most of the times, these imaging findings will resolve. The lag period was mentioned as short as 1 week to as long as 6 months. So even this article and previous literature also suggested to do TCD and keep TCD and bedside for a patient who is having features of sudden onset neurological deficits. We can measure whether the flow is there or not by just doing a TCD on table itself. So considering the anesthetic agent, high doses of volatile hallucinated hydrocarbon anesthetic agent, as in like fluorine group of anesthetic agent is one of the risk factor, it seems, for the cerebral hyperperfusion syndrome. But isoflurane, they mentioned conflicting results. It is having vasodilatory effect on the cerebral blood vessels. In some literatures, it was mentioned as can be taken at minimal volumes for anesthesia for short duration. And propofol is one of the drugs which has tendency to normalize cerebral blood flow and potentially can be used in patient with cerebral hyperperfusion syndrome. So how to prevent? By keeping BP under monitoring, even before and after the procedure, keep a target BP of less than 140/90. And in patient who is having high risk features of cerebral hyperperfusion and previous ICH or uncontrolled BP, in this kind of patient, better to keep below 120/80. The choice of antihypertensive was labetalol to avoid calcium channel blockers, which has vasodilatory effect on the cerebral blood vessels. And there are some literatures which encourage the consideration of pre-procedural edaravone, which has a tendency to reduce the free radical oxygen species. So, but there is no as such, this is only case series, there is no proper evidence of edaravone usage. So, this is one table which explain all these points to keep blood pressure under control and to use labetalol and clonidine to avoid calcium channel blockers. And to consider the procedure within 2 weeks following the recent ischemic event, whether it is TIA or stroke. And type of anesthetic, as I mentioned, any of the maximum to avoid halogenated anesthetic agents. Even if we are, if we are considering to consider isoflurane in smaller doses and better to avoid at higher doses. And propofol also is a good option. Consideration of anti-epileptic medications and hypertonic saline and mannitol, this is case based. If it is a significant edema and patient is having features of either ongoing seizure or if it is status epilepticus like our case, better to consider that. And one more interesting modality of handling a patient, especially who are at high risk, is to consider staged angioplasty, in which the first angioplasty being done by an undersized balloon, maybe 2 mm or 3 mm, then to wait at least for 2 to 4 weeks to restore the compromised cerebral perfusion, because of which the cerebral autoregulation also will get restored. Following that, to consider the stenting procedure. So this is one article which summarize the data. They considered analyzing 525 patient in which stage angioplasty was done in 113 patients compared to one single step procedure in 419 patients. What they noticed is the risk of cerebral hyperperfusion was lower in patient who underwent a staged angioplasty compared to single step procedure. The p-value is 0.04. They have mentioned this as significant observation This is the only study. After that, there are no other studies about this, but the procedure was encouraged after this publication. So overall, to prevent the cerebral hyperperfusion, the pre-procedural risk factors to consider each point like patient factors and then imaging findings prior to going for revascularization, and check the cerebral vascular reserve by TCD or perfusion images. Edaravone, not sure whether it has benefit or not, but can be considered, and keep the BP under control pre-procedure, during procedure, and even after procedure. So during procedure, we haven't considered anesthesia because we can assess neurological status every time after like at each step following angioplasty, and then after stenting, even after post stenting, we can assess neurological status. That is the reason why we didn't consider anesthesia for this patient. TCD is one tool which can be used before and after plasty. Then post-procedural BP monitoring is important factor which can prevent, with which we can prevent hyperperfusion. This is a flow chart which was proposed by the others. Whether if it is like carotid endarterectomy or stenting, if patient is having neurological deficits or any seizure, go for immediate CT brain. Abandon the procedure, go for image immediately. That is the way it was proposed. But rather than going through this flow chart, a case-based, individual-based decision will be more helpful for the patient, I feel. So this is about the patient update. We have discharged patient on dual antiepileptics, that is brivaracetam and lacosamide, dual antiplatelet and statin. Patient went home with MRS1. He had a mild right hand grip weakness at the time of discharge. He was almost a month in the hospital before because of the seizure part. It controlled subsequently, but patient had some behavioral issues because of the levetiracetam at a higher doses. So we have to switch to brivaracetam and then monitor the patient, and we discharged him. He went home 2 weeks back. So in conclusion, cerebral hyperperfusion syndrome is rare but serious complication. Patient selection is important, and pre, intra, and post procedural consideration for the rare but severe complication is important. So always PP control is the key factor. Thank you.
Thank you, Dr. Jafri. That was a very good presentation, comprehensive coverage of the literature. But I would still say that it is more important to have a patient who is cooperative than to be able to examine the patient.
Yes, sir. Yeah.
So we would definitely switch over to general anesthesia. And as you have mentioned, most of the time we use propofol and the TIVA, as they call it. So most of the time it is total intravenous anesthesia which is used. And this is also seen when there is contralateral occlusion. You didn't see shows the opposite carotid at all, so we don't know what is happening to the other carotid. But there may be an asymptomatic occlusion of the other carotid, or there may be contralateral stenosis. So I think it is also very important to look at the, when we say collateral, don't be vague, so we should be more specific. So we should look at the opposite carotid and the posterior circulation. Sometimes the carotid may be supplying the posterior circulation as well. So one should look at the entire, if not necessarily that you have to do the complete DSA, but many times even on the MRA, you can see the ACOM, you can see the PCOM, then you know what, more or less what the collateral is like. So we have seen this both for intracranial and for cervical, mainly when the contralateral carotid has been occluded. And even with the patient's BP being low, they still manage to get a hemorrhage or hyperperfusion syndrome. Luckily, hyperperfusion is not all that common. The staging, I don't know whether it is So one more thing that we do now is in patients over 75, we do not dilate the stent. We accept if there is a residual stenosis because hypoperfusion as well as bradycardia and hypotension are more common in patients who are over 75 in whom the stent is fully dilated. So we try and avoid post-dilatation in patients. We have not done that obviously, but in patients over 75 we don't do that. And about the anticonvulsants, I don't need to tell you, you guys are neurologists. But obviously, if a patient there is contralateral occlusion, we have sometimes given the patient prophylactic anticonvulsant.
Okay.
Or diazepam, keep diazepam ready so that if the patient does get convulsions, you can give a bolus and control the effects.
Okay.
And the other thing is, with the contralateral stenosis, when you do the balloon dilatation, there is a total circulatory arrest. So at that time again, the anesthetic should be very careful and be ready if the patient gets. Usually, as soon as you deflate the balloon, the patient becomes normal. If he's getting a convulsion or if he gets restless or if he has the level of consciousness dips, as soon as you really deflate the balloon, the patient recovers most of the time. So I think what you have done is a very nice analysis of hypoperfusion syndrome. And luckily it is very rare, but if it happens, you should be prepared for it. Very good. Anybody else having anything to say? Anticonvulsants, we have in one or two patients who went into status. In fact, it was very difficult to get the fits under control. And we had to use not one or two, but 4 or 5 drugs before finally the fits were
Yes.
But that I think is more up your alley than mine. Thank you very much.
Thank you.
Very nice.